Thank you so much for this opportunity to deliver this lecture with Matron sponsor and West African College of Surgeons. I'm so glad and I'm happy that I was given the opportunity. And therefore, this day, and behold, today is the first day of the month, so I'm happy and welcome everyone and thanking God that He has kept us alive, even in this pandemic period of COVID, that God is helping us to forge ahead. So thank you, everyone, and welcome. In my lecture this morning, I'm starting with these outlines that shows introduction. In this introduction, we have the objectives, the learning outcome, overview, stroke discussion, meaning of cleft lip and cleft palate, the causes, incidence statistics, then the major thing, nursing management, because the topic is pre-operative management of patient going in for cleft lip and palate surgery. It starts with these other highlights: admission, history, all these things that are on the slide: physical examination, psychological care, nutrition, caregivers, education, medication, and complication, then references. I start by saying that cleft lip and palate is a something is blocking my screen. Dr. Obi, can you take care of that area? Good, excellent. So I'm saying that where is my cursor? Right, I go back again. Sorry. Now, I said that cleft lip and palate are openings or splits in the upper lip, the roof of the mouth, which is the palate, or both. Cleft lip also results when there is a failure of the soft or bony tissues in the upper lip and the roof of the mouth, or both, to fuse during embryonic development. This may occur unilaterally or bilaterally, and may also occur with other congenital abnormalities like spinal bifida, hydrocephalus, some congenital heart diseases, autism, and other deformities found in children. In early life, the facial development of every human being occurs between 6 to 10 weeks in the utero. Facial development occurs between 6 to 10 weeks in the utero. If there's any alteration that occurs during this development, it may affect the formation of the fetal organs. What are our objectives to this lecture? At the end of this lecture, we'll be able to understand the role of nurses in the care of a child going for cleft lip and palate surgery, reflect on the incidence and effects of cleft lip and palate, and emphasize the relevance of nursing care in nutrition and feeding pre-operatively. What will now be our learning outcome? Also, at the end of this discussion, nursing attendees and other medical or surgical health workers, especially the Matron team, will be able to understand the need to reduce complications before and after surgery, demonstrate nursing skills on pre-operative care of patients, and communication skills with patients' relations. Also demonstrate the relevance of effective communication and resource to encourage and support families. what are the overviews? What do we look at? What are the things we look at in cleft lip and palate conditions? The tissues that are, something is blocking my screen. I don't think I like it. Please, Dr. Obi, take care of that. Moderator, Dr. Yebua, can you help remove what is good? I don't want to be saying it is obstructing my discussion. Thank you. Therefore, the overview is that the tissues that form the palate are like a shield running from the front to the back of the mouth and projecting vertically downward on either side of the tongue. The shields move from a vertical position to a horizontal position, and then they are free to meet and fuse at the midline. While this is happening, bone formations occur within these tissues to form the hard palate. Normally, the palate is intact by 10th week of fetal life. The cleft lip and palate defects result from failure of what I have described before, maxillary and premaxillar processes to fuse before the 5th to the 8th week of intrauterine life. The cleft may be a simple notch in the vermilion line, and it may extend up into the floor of the nose. What do we think can cause, or what are the causes of this condition? The cause is not known, but there could be certain conditions that predisposes the mother to have, or predisposes the mother for the baby to now start having, or to have this condition that we call cleft lip and palate deformity. Predisposing factors could come from environmental sources or factors, genetic factors. Like the genetic factors, there are, sometimes it runs from generation to generation. There's a family that have managed in National Hospital that when we took their history, one auntie had it, married to somebody somewhere had it. Then in that family, the wife they married had the child had it. And like that, it run down. When you now pick, you see that about 2-3 generations of that family come up with this condition. Under the environmental things that are around us, all these fumes, the way of life we live, things we eat, these are the things that can cause. And because we don't know, we go on to doing them. Some diabetic conditions, such patients can end up with this, their babies ending up with this cleft and lip palate conditions. Cigarette smoking and alcohol consumption during pregnancy. Then some other diseases like rubella, and some other ones, like some other conditions like obese patient in pregnancy. Rubella causes a lot of deformities, even some heart conditions. There are certain patients that end up with heart conditions when the mother suffers from rubella. Lack of folic acid in pregnancy, anti-epileptic drugs, some drugs that patients will take during pregnancy. I had an incident, I just want to give a scenario. I had a relation, primate, in National Hospital some years ago, who became pregnant but did not attend antenatal clinic earlier. So she said when she feels uncomfortable, she goes to pick an aspirin. And that aspirin is like a tonic, sweet. She even introduced to her old parents. She took it for a long time. She delivered this baby. You need to see the deformity on this pretty child. So certain drugs we take during pregnancy affects these conditions on the baby. And here, another slide that we have for incidence or statistics. When you look at, you see in America, the amount of cleft lip palate conditions together, the prevalence, the UK, and in Nigeria. In Nigeria is 1 to 1,000 cases, but not all are reported. Many, many cases are unreported in Nigeria because of our situation, because we are underdeveloped countries. So records are not there. Even childbirth, they are not there. Now, nursing assessment or nursing management. In UK and some other countries in the world, like Nigeria, a cleft lip is usually closed. It does close we do close it. Surgeries are done. Some do from 2 to 3 months, but we in National Hospital do at 3 months. But some are also beyond 3 months, unreported cases that don't come on time. While palate is closed between 6 to 9 months. Child must be free from chickenpox, upper respiratory tract infection, and other viral infections, so that by the time you do this surgery, the child will come out without complications. Child nutrition is important. These are the things you look into or you look at while bringing this child to go in for surgery. Child must be adequately fed and make sure child is not anemic. The family must have an opportunity to discuss any procedure to be undertaken during the surgery and must be free to ask questions, because some came based on the belief of the cause of this condition. Some say a taboo, the woman would have caused one problem or the other. Either she promised, she did adultery, or some say is one god or goddesses. A lot of belief in our environment. So there's an anxiety, there's in the parents of these children. Therefore, it's good that during this period of surgery, trying to do this correction, you allow them to ask questions. Now, it is of utmost importance to note that as patients come in for surgery, they start from the clinic. In the clinic, the nurse attends to them with the doctors, and when agreement is made, patient is convinced that surgery will be done, patient is admitted. So pre-operative care of nursing care of this patient starts from admission into the ward. In the ward, a nurse is advised, is trained to show a professional relationship by giving a smile. This woman or this parent, they are coming in with anxiety, anxiousness, and they've not been to that environment before. And when right from their home and their family, they say their child is going for operation. Now it's a big thing. So you give them a smile, show them love, introduce yourself, and receive this patient. While you do that, the next thing is to collect their data. Give them a seat, they sit down, make them comfortable, you collect their data. The data, name, sex, age, date of birth, their religion is important, because here in Africa, we respect people's religion. Tribe is so important also, because in case you're not understanding, you bring somebody who understands that language to interpret. Then the address is important. Most people that come from rural areas don't have addresses. So what they do, they call the name of their village. Then so compound, hamlet, you use it to trace them. Now, the next thing is to do when you receive this child, you do physical examination. On your physical examination, The first thing a nurse must do is to do vital signs. The vital signs of this child is the heartbeat, the temperature, the pulse, weigh, a lot of weighing. In this weighing, why do you weigh? You weigh because an anesthetist that is going to put this child to sleep will know the weight as to know the quantity, the gram of dosage, the dosage of drug to be given to this child. The temperature, in case the child is running temperature, or in case the child has infection, it is detected and surgery can be postponed depending on the level. Heartbeats, heart sound, color of skin, some come with rashes, skin rashes and all that. So you take care of all these and report accordingly. Infants, neurological status. Is this child alert, responsive? These are the things, because some autism babies have cleft lip and cleft palate. These are the things you record and let the surgeon know, because some things that are omitted in the clinic should not be omitted in the ward on admission. So a nurse takes complete and comprehensive history of these parents and let the consultant, the doctors, the team know. You collect lab values. Under this lab, it would have been filled in the clinic. If they did not, you call their attention. They will do this sample collection. You submit and make sure you retrieve all. You admit this patient in the ward by assessing which of the patients that have just had this surgery. Because when they see a patient that has finished, that has come out of that surgery and is healing, they feel happy. Use them as an example. Can you see this baby? This baby is doing very well. They will have double assurance that they are in good hands. So it's important you position a patient on admission close to the next patient who has had similar surgery, and they're good to go. You introduce,
Matron,
sir.
Hold on. I want to let the audience know that they can send their questions to the chat room. Please, if you are on, you can send all your questions to the chat room as the lecture is still going on, so that you don't forget your questions. Thank you very much. Mommy, please continue.
All right, thank you. So I was talking about admission. As you admit them, remember they are new to that environment. It is the duty of this nurse to introduce the parents to the environment. Show the parents where to keep this, keep that, the toilet ends. This is what we do, rules and regulation of that environment, so that they can have a free, infection-free period throughout admission in the hospital, or even in the clinic, anywhere, small hospital where surgeries are done. I'm speaking from a bigger hospital because I have been working in a big hospital. So another important thing that is so important is psychological care. Remember that these mothers, parents come with anxiety, fear of unknown. It is the duty of the nurse to take care of these caregivers by allaying anxiety, reassuring them. And what you do will also prove to them that, of course, what she's saying or what they are saying is true. That for you to do any procedure, you tell them why. Introduce it to them. They will accept it. There will be no resistance. So it brings coping. It makes everybody fall in line with the management and they obey you. And that reduces anxiety's guilt, because the parents feel they would have been the cause of this to this child in one way or the other. So as this is going on, the parents will be happy. Everybody will, the psychological condition of this, they will be free to ask you questions. And at this time, whatever they ask you, it is very important you answer them correctly. Give them hope. why they are with you, nurses. And they say nurses cold, nurses are aggressive, that. If you are in a mood that does not befit your career, you at that point pause and remember your services and you do the right thing. And people will commend you. You'll be happy that you've rendered a service that is unto God's glory. Nursing is nursing care is something between God and man and humanity. You introduce also the MDT teams, the multidisciplinary team to this patient, the surgeons, the anesthetists, because they come around, they will review them before going in for surgery. The anesthetists, they will come, ask questions, do one or two things, write pre-op medications, dietitians, physiotherapists, psychologists, and other nursing team, because it's not only you. We run shifts. We know we have our category of nurses that cover the period of admission of this patient. Then nutrition. Under nutrition, you make sure that this patient is well nourished. If the child is not nourished, there's anemia, you report. Where dietitian will come in, they will come in and make sure it is rectified before surgery. You don't take a half an anemic patient to. It's true, during surgery they don't bleed, but you cannot predict any surgery. What you think you see might not be what you see, because I'm speaking from the point of a pre-operativeness. Then feeding. Before this time, remember, this deformity causes the children not to feed well. They feed, they have gas, but if you train them well and teach them, if they come out early, if they deliver in the hospital and it is known, these conditions come out well, they now come back for surgery. Child will not be sick. But those that deliver in traditional birth assistant or with the QQ or whoever somewhere might not know all this. So during feeding, you make sure that they feed with the breast milk. Teach them the method, and the child will receive adequate breast milk and will look good and be fit for surgery. Caregiver education. This is very important because it's not the baby that is a concern. The caregiver, the parents are also consigned to this, because the mother, the father have high expectations from you, the medical team. So you teach them a lot. You make them to know the type of surgery the child will be going through. This will help to allay anxiety, fear. Explain the type of procedure and what to be performed, and explain the routine, pre, in, and post-operatively.
Well, they get no show.
Have a written information, if possible. Some hospitals do have written information that you give to caregivers to go through your do's and don'ts, what to do. Because when you train them, when you educate them, post-operative care, they follow it very well, that the child healing will be at first intention. There will be no problem. But when they don't have knowledge, before you know it, that surgery might be infected. So it's good you give them a good training. And where you have a written information, you give it to them. If the language is not, you bring it to the language of the patient in case they don't understand the English we speak. Then you obtain consent form. I want to emphasize here that consent forms are obtained from the clinic. That is the standard. But what we see in our Nigerian sector, affair in this hospital and somewhere, is that some patients come to obtain consent form in the theater. It's not acceptable. So if you omit it in the clinic, it should not be omitted in the ward. So the nurse must make sure consent is obtained and signed. And then you continue to reassure parents. Any question, be ready to answer. If there is pre-operative medications written, you serve. But if there's no, you don't. Some can be written for you to take it to the theater. You go along when the patient baby is taken to the theater. At that day of admission or a night before surgery, you make sure that this baby will have a warm bath so that baby can sleep well. So there are other things you do. You also make sure, because you have to monitor mothers, teach them that baby will feed last 6 hours before surgery. As you say that, you monitor them. Some will say baby was crying, they will now go and feed. That will alter the whole thing. If they didn't tell you, there'll be a problem during anesthesia in the theater. So these are the things, because if you educate them very well, they'll be happy, they will obey you, and surgery will come out well. And each thing you have done as a nurse, you document. A day of surgery. The day of surgery, you encourage the mother, groom the child, allow the mother to participate, bath the child, get the child, and not to put any cream or whatever. But it's true that this surgery is on the face. There is no shaving. Like other surgeries, you shave, but here you don't shave. More so is a child, so the hairs are not there. You prepare this patient file accordingly. There are things you must not omit: the lab results, the consent form, the drugs, if written, to be taken to theater. These things, you go with it. Then insert your identification band. Change patient to theater outfits. Take patient vital signs, because there will always be the last vital signs before you leave the ward, and you document properly. In case what you got yesterday is different from what you're getting at that moment, you alert everyone. Then you now move this patient to the theater and hand over to the pre-operative nurses in the theater accordingly at the red line. Now, when you do this as a nurse, a lot of things will be avoided. These complications that come in after surgery, like air obstruction, hypothermia, bleeding, edema, aspiration, and others. When things are done well and surgery comes out very well, you will not have such complications. I have on my slide feeding, but I know that feeding was treated last by one of the doctors. So I'm passing through that slide and I'm going straight to my references. So thank you so much. And this is where my lecture ends. Thank you.
Thank you very much, Matron, for such a wonderful presentation. Matron has given us a brief presentation on preoperative care nursing, or operative nursing for patients going for Cleft surgery. And she gave us a bit of introduction and some epidemiology, the causes. And then he has also elaborated on the stepwise procedure that you have to take care of the babies as they come in at the clinic, and then as they go to the ward, taking care of their feeding, taking care of their bathing, taking care of almost everything that has to be done before the surgery is done. And also making sure that the baby sleeps very well before the surgery. That was very important. We should all admit, I think most of us admit that no matter how long a doctor speaks to a patient, to go back and ask the nurse, what did the doctor say? So nursing care is so important. And caregiver education by the nurses also are very important. Now I'll move to the chat room and then look at the questions that are coming. A lot of questions are coming now. The first question that I can see here is that for first-time cleft palate surgery, what is the obligatory lab examination you do? Yes, what is the obligatory lab examination you do? I have rephrased the question. I hope the one who sent it, if that is not correct, can send it again. Rose Faye. That is how I understand the question. It says for the first time cleft palate, what is the obligatory lab exams you do? Let me add one question so that you take the two together. He said that how long do your patients stay on the ward before they are discharged after surgery? And then how many days do you admit them before surgery? So, Mommy, if you can take these two questions, then we can come back.
Let me start from the last one. How many days they stay in the ward cannot be fixed. If it depends on the condition where as the child was admitted. If the child is admitted normally without any problem, because they would have managed infection, every other thing in the clinic before booking for surgery. Yes, the child, 24 hours, the next day child goes in for surgery. Except along the line, there's something that crops up, continuous running of high temperature. They will pause and want to revisit what could be the cause. So such things will alter the day a child surgery will be done. I hope I have answered well. Now, the other one is the lab investigations. Is the PCV, packed cell volume, hemoglobin, serology, and bleeding profile. It's important to note these things. From these blood PCV and HB, you'll be able to know the level of blood in this child. Like I said in my lecture that cleft lip palate surgeries, they don't bleed as such, but anything can happen. If there's anything that happened and there's bleeding, of course, you will always take care of it. So these are the lab investigations that are done. Blood profile, blood bleeding profile, serology, hemoglobin, PCV.
All right, thank you very much. It said that if a baby come in malnourished, what do you do before surgery? And then I'll add another question, which says that, well, thank you for your presentation. What is your post-op oral feeding protocol following cleft palate repair? I'm not sure, but if you can answer this question anyway, but I think there is a lecture on post-operative nursing care. Yes, but you can still make a comment on that question as well. Okay.
Right. The first one is if a child comes malnourished. To the glory of God, Matron has made a package for cleft lip and palate surgery babies in Africa, in Nigeria especially. They have included nutrition in their care. So by the standard of what we do, we don't expect any child to come malnourished. But if, yes, there's a package that you now bring in dietitians, because in a cleft team, the dietitian is there. Social welfare officer are there. So these are the things, the people that, so you now bring a dietitian that will now change the feeding of that child so that the child can come to a near normal or normal even, not near normal, that child can withstand surgery. So you will always handle it and treat it. Because there's now a nutrition package in our Cleft care for Nigerian children.
All right.
Then the post-operative oral feeding protocol. Now, somebody is going to handle it, you have rightly said. The oral feeding protocol post-operatively is always based on the doctor's recommendation, the pre-op condition, how the child is coming out. I have had a child in the theater here that came out because of bleeding. They took the child, they arrested the bleeding in the recovery room in Paco, and child spent some hours instead of 1 hour back to the ward. By the time you know it, this child was hungry. So everybody, after assessment right here, mother was asked to feed, and mother expressed the milk, breast milk. We now fed. The professor that taught the other day said they don't do syringe or bottle feed. I don't know what she said they use. I think I can't. Let me not quote her wrongly. So, but we now right there in the post-operative, we use syringe just to trickle down a little milk of a little quantity after anesthesia review. You must review. Anesthesia will always discharge our patients in the pre-operative, in the PACO recovery room to be sure that this patient is living in a good condition. Right in the ward nurses, because I manage all of them, will also be ready, putting all equipment ready, suction machine, this, everything you can think of, to make sure that there will be no problem. And most times we have not had any incident to such.
Okay. I think there's a follow-up question from another person. He said that as a head of nursing units, NHA, what role did you play in creating awareness to all the other nurses at the AMAC General Hospital and then the PHCs, since they mostly attend to low and middle socioeconomic class of people? That's a follow-up question. And then the next question, I'm adding another one so that you take two. Okay. Is it all the babies that can not breastfeed directly? His experience or his experience from their center shows that some of these babies breastfeed well, even with bilateral deformity. What is your comment on this?
I didn't say they breastfeed well. They don't breastfeed. You express the breast milk and feed them post-operatively.
Okay.
Yes, that's what I say, so that they don't misunderstand me. That is that aspect. Then in the first question from National Hospital, we have put down a teaching program that we call Step Down, because it is good to pass it on. My lecture ends with passing it on. You pass on to other nurses. You pass on to other, and those people you pass on to will pass on and pass on. So when you pass on, train a lot of nurses, they now go and implement the training you've given them in the ward. They now pass it on. So we now move from place to place, hospital to hospital, any clinic they can find themselves, because some of them too run some clinics in the town. So they pass it on. And when there's any problem, they fall back to us. But I've never had an issue, somebody calling me up to say, so what do we do in this condition? So I believe that everything has been going well, except they don't want to tell me. But I know that all the passing it on, training we have given have been moving from place to place. We have trained a lot of nurses, and we are still going to train more.
Okay.
Right.
All right. Thank you very much. The next batch of questions is, what is the ideal fasting hours for an adult before cleft palate surgery? And let me see if I have more. I think I have 3 more. Okay. Okay, that's the same question. Okay, this one says, have you found it necessary to use nasogastric tube feeding for the cleft patients preoperatively?
Come again, please.
It said, have you found it necessary to use nasogastric tube feeding for the cleft patients preoperatively?
Yes. Yes. Because depending on that level of the child, because they come out with nasogastric tube, some of them, especially the bilateral, they come with nasogastric tube. So you feed through nasogastric tube. You do feed through nasogastric tube. Now, the milk I said we gave to that child was also not, we didn't use that because it was just a unilateral cleft repair. So, and it was not a severe one. Like I said, child was assessed properly. And immediately we trickled down those little drops of milk, breast milk, the child remained calm and was not able to transfer to the ward. Management continued in the ward. That's what happened. Now for adults, 6 to 8 hours is the timeline for nil per hour before surgery.
Okay. All right, thank you very much. The next questions, right, I think Rose has come back with a more explanation of her questions. He said that we do some examinations before the surgery, but sometimes we have problems. So they want to know if there are selected laboratory exams that must be done before surgery. And then
bleeding profile is very important.
Okay.
Yeah, very, very important. And okay, for now, HIV, because I know those things are, in case you're dealing with a mother with, because history will tell you where to tilt your investigations to. If your protocol in your hospital is that every patient that will undergo surgery, you must do HIV tests, you go on doing it. Now that there's COVID, if it's going to be your protocol, of course you will do, because we are operating in the mouth. It's oral. So since the infection, the pandemic that is ravaging us now, is the root is the eye, the nose, the mouth. Of course, if your hospital decides to have a protocol that goes to do with that, you will do it. Then hemophilia, that's another thing I remember, yes, you can also take care of as investigations.
All right. So, yeah. Okay, thank you very much. So let me take, I think, the last question, if I'm right for now. But concerning the lab, let me just say a word on the lab before the next questions. I think from the Matron guidelines, you need an HB. So the FBC is constant. It's obligatory for any patient that is going for surgery. That one is obligatory. FBC is obligatory. And the other lab investigation depends on the protocol of that particular center. But the FBC or the FBS is constant. It's obligatory everywhere. It has the baseline. Then you can add whatever you want to add depending on your center. I hope that also helps. Right, so the next question, more questions are coming. Okay, so the next question is that, how do you encourage a cleft baby's mother for optimum feeding? How do you encourage a cleft baby mother for optimum feeding? The next one. Okay, this one, they're asking me to tell them when the next lecture is. So I think that's the last question.
Okay, pre-operatively.
Yes. How do you encourage the mothers to breastfeed or to feed their babies well, pre-operatively?
Right. Like I said, if they did not deliver in the hospital, a lot of things go wrong out there. But if they deliver in the hospital or along the line you come around across them, they are now in your care. Of course, there's a teaching you do. Remember, there's a space. You encourage the mother to, there's a teaching you do to use your finger and cover the space to prevent air going in while the baby sucks, so that the baby can grip the remaining nipple, the areola properly, and be able to suck in the milk. That's if baby is breastfeeding. Some other ones that are not breastfeeding, because some other patients too, for one condition or the other, they might use either, no, we don't encourage bottle feeding now. It is not a Ministry of Health recommendation. So when you say it, you know that those people are doing it on their own, but they must take absolute care to be sure that there's nothing, no infection, gastroenteritis that will come onto this child. So you encourage them, you teach them, you be there, support them. There's a position you give them. There's a way they sit, we call it L form. They sit in an L form as to be able to feed this baby properly, and baby will get enough milk to survive and look nourished. I don't know whether I'm true. Am I okay?
Yes. You are very much okay. I think the questions are done. I don't know why I can see your video, but people say they can't see your face.
Oh, sorry, my face. Okay, let me. Can you see me now?
Yes, we can see you, Matron.
That's me.
Keep your face to the video portion.
All right, ma'am. Thank you.
Okay. So I believe everybody can see our mother now. Yeah. Everybody can see her face now.
Thank you. You are my brother, my Ghanaian brother.
So thank you very much, Matron. Thank you very much, Matron. We appreciate your time.
Thank you.
And your
thank you for West
expertise.
African College of Surgeons. We are grateful.
Your expertise and sharing your time with us. We are grateful.
Thank you.
On behalf of Matron and West African College of Surgeons, we say thank you very much for honoring our invitation. And then the audience and the participants, and we appreciate your presence, your time with us, your questions, wonderful questions, and the discussion that has gone on. We say thank you very much for joining us. And then we also want to appreciate Matron once again, and West African College of Surgeons for putting this together so that we share knowledge and increase and optimize our care for our patients. Tomorrow we'll continue Same time, same place, and I think same moderator. Okay, so thank you very much for everyone. Now, NK, can you please take over?
Thank you so much. Thank you, Matron Opara. That was a great presentation. Thank you, Dr. Obiri. Excellent moderation. Tomorrow promises to be another great time, and we'll be talking on atypical clefts. Come tomorrow, 11 a.m. Nigerian time, and join us for an interesting journey into the cleft care world. God bless you and happy new month. Bye-bye.